I'm a faculty member at the Upstate Medical University Department of Family Medicine and the UHS Wilson Family Medicine Residency. I'm presenting this talk today as a online version of a talk that I give live to my students and residents so as to give you more background information on how to do an excellent well child checkup and even more when you're doing good work on health maintenance for your patients. So let's get started. Here's a look at a typical schedule that you might see walking into my office or the office of a lot of primary care doctors. You'll see a wide variety of visits, and I have an observation after hosting medical students in my office practice for almost 20 years. You guys are generally quite good at several of these visits. You guys are good at the visit for a child with a rash. You're good at a visit for a twisted ankle. You're good for the patient who comes in with a cold and maybe a sinus infection, a complaint of swollen lymph glands or abdominal pain, or maybe an adverse reaction to a medicine or bruising. Now, it doesn't mean that you've got every idea perfect and you'll have fantastic diagnoses and plans, but you're good at going in the room and doing productive work with the patient, even as students. Why are you good? Well, it's because as you stand outside the room prepping for the visit, seeing that Mrs. Jones is here and she has a complaint of a twisted ankle and thinking over how you're going to do productive work in the room, you have a plan. You know how to do this kind of work because you have a strategy. You know that you're going to go in, introduce yourself, and get right to getting a history of present illness, a chief complaint, 7, 8, or 9 cardinal descriptors of the chief complaint, and however many you've been taught, like onset, location, duration, quality, severity, better and worse, and all that stuff. You're probably going to add any pertinent reviews of systems that help to clarify the chief complaint. Then you're going to get any background history information that you think will add to your understanding of the patient and their complaint. Past medical, past surgical, allergies, medications, social history, family history, whatever you think is appropriate. Then you'll do appropriate physical exam, again, to give you more ideas about what might be going on with the patient at hand. Then you'll do some thinking. You'll construct a differential diagnosis of the possible diagnoses causing the patient's complaint, and then you'll propose a plan, how you're going to get to work on diagnosis and treatment productively with the patient. You guys are good at this kind of visit because you've been taught it so well. When you're standing outside the room prepping for an acute complaint visit, you know that the plan is take a good history, get background history as needed, do physical exam, make a differential, and propose a plan. Now, I've also observed over almost 20 years that you guys are not nearly as good at some other kinds of visits, such as the adult who comes in for his quote-unquote annual physical, or the 18-month-old toddler sitting on mom's knee who comes in for the 18-month-old well child checkup. And I'll tell you why I think that you guys are not so strong at this visit. It's because when you're standing outside the room getting ready to see that toddler for a well child checkup to keep the kid healthy, where there's not really a complaint, you may not really have a plan. You don't have a strategy. Because the one strategy that you were taught ain't going to work. Typically, this is a complaintless visit. So there is no history of the present illness, because if all goes well, there is no illness. This is a healthy 18-month-old here with mom. Then, you don't get to construct a differential because there's no acute problem, so there's no diagnosis to pursue. And lastly, the plan for health maintenance is really nothing like the plan for working on a problem. Here's another reason why these health maintenance visits like well child checkups are tough. There's an overwhelming amount of disorganized information to pursue. Here are the Texas Medicaid forms from a few years ago. Here, front and back, are things recommended that doctors go over for a 2-month-old well child checkup, which is different front and back from a 12-month-old well child checkup, which is different again from a 3-year-old's well child checkup, front and back. That's an enormous amount of stuff to master. And I know back when I was a student and resident, I felt overwhelmed. How could I possibly get good at this overwhelming, confusing work? And then I realized maybe I could make headway if I had a strategy. Maybe I could do a good well child checkup without any forms or checklists or prompting from paper or EMR templates. If I had a plan, if I understood what was common to all of those kinds of visits. The first thing to observe is that all these other visits, all of these acute problem visits, the patient brings the agenda, right? The agenda, whether spoken or unspoken, for the patient with the twisted ankle is check out my ankle and help me feel better and heal up from it. The agenda for the follow-up blood pressure visit is help me with my blood pressure so I don't have a stroke in 30 years. The agenda for the abdominal pain visit is help figure out my abdominal pain, help me feel better. The visit for gout, the agenda is stated, help me with this condition of gout, help me not suffer attacks. All visits, the agenda is pretty clear, except for the well visits. The patients dutifully show up, but they don't know why. They've been told that we have a good package of services to give them or give their child, but they don't know what those services are, and they trust us to have a vision of what those services should be. So we need to have a good vision of what to work on, what to get done at these visits to make them fruitful for patients, because they don't know. So we need to think of the items that should go into these visits. And the items are really of our choosing. So let's choose some. What kind of stuff should we do at the checkup for a cute 9-month-old baby? They're a lot of fun. They're happy and healthy, but we should do productive medical work on behalf of maintaining the health of this child now and going forward. So what should we do? Now, when I do this with a live audience, I ask the audience to name items that they've seen at well child checkups, and then I group them into categories. Of course, because there is no live audience, we'll just move right to the kinds of things that I've heard. So here are typical answers that I have heard from medical students. When we do the checkup on a 9-month-old, doctors do things like listen to the lungs, or look in the ears, or measure the kid and plot it on a growth chart. We ask questions like developmental questions. I'm going to group these into a category called screening for disease. And I'd like to point out that we're mainly screening for unseen disease, because if the parents saw some kind of trouble that was obvious, they would have made an acute problem visit weeks ago to bring it to our attention, to work on an acute problem. So we're usually looking for things that parents can't appreciate, like something going on with the heart that only we can hear, or a growth abnormality that only we can pick up because we've seen hundreds and thousands of children and we have these growth charts which show us the trajectories of normal growth for normal children. And we've been trained to know how children should develop. So we ask the right questions at the right time and have a sense of how that might vary. So we are ideally situated to assess and screen for disease, especially unseen disease. The second thing that students will say is, well, they give a lot of vaccines at those visits. And that's true. Vaccines are super important. They are profoundly impactful on the lives and health of children and entire communities. So that's kind of its own category, but I'm going to broaden the category slightly. Instead of just vaccines, I'm going to call it preventive chemicals in general. If you like to be fancy about it, you can call it chemoprophylaxis. And you'll see when I give some examples later on about why I'm broadening it. The third thing that students usually pipe up with that they have seen at these kinds of visits is talking stuff. Doctor and parents discuss stuff like what their kid is eating, whether they're brushing their child's teeth and bringing them to a dentist, safety stuff like a car seat and bike helmets and walkers, baby-proofing the house, that kind of stuff. Doctors, they talk about secondhand smoke. I'm going to group this kind of talking advice giving stuff into a category that we'll call health counseling. You could also call it anticipatory guidance or patient education. This is the talking and advising category of activities. Now, if this three-part scheme really describes what we do at well child checkups, it ought to be a good roadmap for the things we do at any well child checkup. So let's see how that plays out. Let's see how well this scheme that we developed for a 9-month-old well child checkup, let's see how well it does for a 4-week-old baby checkup. What kind of screening do we do? We ask developmental questions like paying attention and hearing and recognizing parents' voices and head control. We do height, weight, and head circumference to check for growth disorders and failure to thrive, which might reveal and hint at an unseen disease. We check the fontanelles. We listen to the heart. After all, 3% of babies are born with any kind of birth defect, and 1/3 of those are cardiac. We check for femoral pulses for circulatory sufficiency. We check for descended testes. We check the red reflex, screening for the rare cancer retinoblastoma. We check for those dislocatable hips with those hip maneuvers, trying to pop them in and out of their sockets. Right? These all represent screening for disease, and mainly things that the parents themselves could not pick up. Then we talk, and we always talk lots of safety, like car safety seat, properly installed, facing backwards. We give advice on safe sleeping, like the entire Back to Bed campaign, which has been profoundly beneficial for reducing crib death or sudden infant death syndrome, just by recommending that babies be put to bed on their back in an uncluttered crib without bumpers and blankets and pillows and stuffed animals. That's been profoundly impactful. We talk about smoke detectors. We talk about carbon monoxide detectors. We give advice on shaken baby syndrome and calming a child. We give nutrition counseling, like what to feed your baby, and at 4 weeks, that's either breast milk or bottle with formula. And this is a good chance to say good things about breastfeeding and provide support and assistance if a woman has questions or difficulties. We give counseling on secondhand smoke. We talk about baths and peeling skin. We answer all kinds of questions. We might even talk about baby acne, which starts around this time. How about preventive chemicals? Well, at about 1 month old, depending on the schedule you're using, there's probably a hepatitis B vaccine. But there's another preventive chemical that is not a vaccine. For infants of exclusively breastfed moms, there's also that vitamin D. And that's not because breast milk is imperfect, because it is the perfect food for any human baby. It's because women themselves are vitamin D deficient, and so their breast milk doesn't have enough. So this is an example of a medicine given not to treat a disease, but to prevent the disease of vitamin D deficiency and rickets. So far this scheme works pretty well to describe the things that we could and should do at a 4-week well child checkup. How about at a 12-month baby's checkup? Right? This is quite an entirely different person that we're talking about. At 4 weeks old, they're a cute pink little ball of warmth and joy, but they don't do much. At 12 months old, they have personality, they're on the move, they're communicating. This is an exciting, energetic child. So what do we do at their checkup? Well, we ask developmental questions. Different questions, of course, compared to the 4-week checkup, but the same topic. And the same category, we are screening for unseen disease of developmental delay. We do height, weight, and head circumference, again, checking for growth abnormalities which might suggest an unseen disease causing failure to thrive. We might check the red reflex. We're probably now going to check for conjugate gaze, because if we detected esotropia or exotropia, we might then guide intervention to avoid amblyopia. And here's the first time that a test goes into our scheme, because we don't only screen for unseen diseases with history questions and with physical exam, but we also do it with labs and images and workup, such as the 12-month lead level that we certainly do in New York State and elsewhere for high-risk babies. What about counseling? Well, of course, again, we're doing safety, like car seat, but we're no longer talking about the Back to Bed campaign. Now we've got a kid who's crawling and cruising along the furniture and walking and maybe climbing stairs. So we're talking about baby-proofing the house, like putting outlet covers over the electrical sockets and putting up gates in front of stairways so that kids don't go down the cellar stairway. We're talking about moving liquid Drano from under the sink to a high shelf where the kid couldn't accidentally be poisoned. That kind of stuff. Maybe we're talking about cow's milk. We're certainly talking about what to feed your kid and how to do so in a nourishing fashion. We're talking secondhand smoke. Maybe we're talking about stranger anxiety. Maybe we're talking about daycare and all the infections that children can bring home and contending with a child who has colds all the time. At 12 months old, we're giving baby vaccines. There's also the flu vaccine at that time, and there's fluoride. For a child who is on unfluoridated water, such as well water or municipal water where the water is not fluoridated, we do fluoride supplementation when teeth first erupt. So this is another good example of preventive chemicals, including vaccines, but also a few things more than just vaccines. So this template does a good job of describing what we do at a 4-week baby checkup and a 12-month well child checkup. But if it's a really good scheme, it ought to do a good job for any well child checkup. How about the really different person that a 15-year-old is? Well, at this age, we're probably not doing developmental questions, but there are a lot of other things we're concerned about. How about substance use screening, tobacco, alcohol, and drugs? There's questions about sexuality, sexual orientation, and how they're doing with their orientation, sexual activity, risk factors, all kinds of things we want to know about so that we can bring good things to the health of this teenager. Diet habits, after all. Obesity is an epidemic in teenagers these days. So we're asking about diet habits, we're measuring the child's weight looking for obesity, we're measuring blood pressure. Now, we used to check for scoliosis. So scoliosis used to go in this box. Now we know that screening for scoliosis is not such a good idea, and we're going to remove it from this box. But in order to talk about things that you're familiar with and have probably seen, scoliosis is something a few people might be doing, and it goes in this box. If we were doing a sports checkup, we might screen for that unusual heart murmur of idiopathic hypertrophic subaortic stenosis. It goes in this box, the screening for unseen disease box. How about counseling? Well, counseling is incredibly important for teenagers. So not only are we going to ask about tobacco, alcohol, and drugs, we're going to counsel on them. We're going to give tons of advice about sexuality. We're going to give lots of advice about risk-taking behavior. We're going to give tons of advice about safety stuff. Maybe not bike helmets so much at this age if they're not riding bikes, but certainly seat belts, certainly car safety, like not driving with people who are texting or not driving with people who have consumed alcohol or drugs. This stuff is so important. And this is a good time to remind you that we counsel teenagers that they get confidentiality in the doctor's office so that they will bring their issues to us so that we can work on them when they have concerns or acute problems. Now the 15-year-old gets some special vaccines, right? They should be well along their HPV series. There's the meningococcal vaccines now at 2 ages during their teen years. They get a tetanus pertussis booster, and of course they should get the flu shot. Now, patients, and unfortunately some doctors, think that the physical exam part of a, quote, annual physical is the high-yield part of this kind of visit, whereas this talking stuff is soft, fluffy, quasi-medical. It's something that those family doctor types do, but it's not real medicine. Well, I'm here to tell you that this is real medicine. Now, those of you going into orthopedics might think differently and poo-poo and say that real medicine is titrating a nipride drip in the ICU and running the vent settings. And those are important things, and I can do them. I have. But when it comes to maintaining the health of children, each of these has important contributions. For instance, what is the number one thing that kills children in this country. After all, this is a health maintenance visit. The whole idea in the name of the visit is to keep this kid healthy for another year until you do the next well-child health maintenance visit. So you would think that we would want to address the number one thing that kills children. What is the number one thing that kills Americans in their first decade of life? It's accidents. What's the number one thing that kills Americans in their second decade of life from age 10 to 19? It's also accidents. What's the number one thing that kills Americans in their third decade of life? Accidents. What's the number one thing that kills Americans in their fourth decade of life? Accidents. What's the number one thing that kills Americans in their fifth decade of life? Heart attacks. It takes until people get into their 40s for heart attacks in this country to start to outstrip accidents as the leading cause of death. What prevents accidents for all those children, teenagers, and people in their 20s and 30s? Does a screening test prevent accidents? No. Does a preventive chemical like a vaccine prevent accidents? No. Only health counseling does. Only health counseling like the Back to Bed campaign. Only health counseling like wearing your seatbelt. Only health counseling about drinking and driving and texting while driving. Only health counseling about drowning. Only health counseling about smoke detectors. Only health counseling can prevent these unnecessary preventable causes of death, the number one thing that hurts and kills children. So, even though it doesn't feel hardcore medical like titrating a drip in the ICU, it is hardcore medical. And if you're going to do it at a high level of skill, you need to cultivate your ears and your mouth to listen, understand people, ask questions, educate, negotiate, and help guide them to good behaviors for themselves and their children so that we can prevent these awful things. Now, this scheme seems to be pretty good for babies, toddlers, teenagers. I wonder if we could use it on adults. Does this scheme describe the things that we do for a 24-year-old's annual quote-unquote complete physical exam? Well, let's go ahead and see. Do we do screening for disease? Of course we do. We screen for substance use disorders by asking about alcohol, tobacco, and drugs. We screen for sexuality issues and risks. We screen for workplace exposures. We screen for domestic violence, a terribly common, sad thing in the lives of especially women. We screen with weight and blood pressure because there's an epidemic of obesity and hypertension in young people. And if your patient is female, we're doing a pap smear screening for cervical cancer, the most phenomenally successful screening program that I can think of. We're screening for STDs like gonorrhea, chlamydia, probably HIV, that's recommended. We're probably screening for depression. There's all kinds of things that go in this box. Now, how about counseling? What do we counsel 24-year-olds? We always counsel on safety. We counsel on substance use. We counsel on sexuality and family planning stuff like contraception for those who don't want to conceive pregnancy and family planning for those who might want to conceive pregnancy. We talk diet and exercise, staying fit so that people don't age into their 30s and 40s with obesity, hypertension, and diabetes, which we see all too often. We talk about the value of disease screening in general. There's all kinds of things that you can put in this box. How about preventive chemicals? Well, there are certainly vaccines that adults need, like a tetanus booster every 10 years and a flu shot. Let's go to a 65-year-old. Right now we're at quite a different end of the lifespan. Does this scheme of screening, health counseling, and chemoprophylaxis describe the work that we do at a 65-year-old's annual checkup for health maintenance? Sure does. We screen for substance use. We screen for weight and blood pressure. We're probably screening for diabetes and hyperlipidemia and risk of heart attack. We're screening for depression. We're screening for bone density. This is the first bone density test for women of average risk at age 65, maybe earlier if they have special risk. We're screening for breast cancer. we're probably doing a woman's last pap smear of her lifetime at 65. We're screening for colorectal cancer, highly beneficial. And hey, here's a new one. We're doing one of those low-dose CT lung cancer screenings for those who have smoked substantially in their lifetime so that we can find lung cancer early and improve outcomes, right? It's a new item, but it goes in an old box, the screening for disease box. How about counseling? We're counseling on safety, we're counseling on substance use, we're counseling on diet and weight-bearing exercise, especially for the ladies who have such awful troubles with osteoporosis when they reach their 80s. We're going to counsel on healthcare proxy and advanced directives, right? We're probably not doing that for the 15-year-old, but we are for the 65-year-old. Completely different kind of topic, but it goes in the same agenda item of health counseling and anticipatory guidance. What about preventive chemicals? Well, there's vaccines for older folks like flu shot and pneumococcal vaccines. Then there's that calcium and vitamin D that we recommend, right? The calcium is iffy, the vitamin D is probably a good idea. If you do these and you believe in them and if the evidence supports them, they go in this box. How about that baby aspirin, right? Now, if someone has had a heart attack, a baby aspirin every day is treating the disease of coronary artery disease. But if they haven't had a heart attack and we're doing primary prevention, we recommend a baby aspirin every day to prevent a disease. It really belongs in this box of chemoprophylaxis. Now that we understand that there are these 3 boxes for any visit, we can have these great educational conversations, you and me, attending faculty physician and student and resident learner. We can kick around what should go in these boxes. Should we screen for sugar? Should we do screening lipids? Should we do screening urinalysis? Should we do screening TSHs? Should we do screening EKGs? If we decide that we should do depression screen, how are we going to do it? Why? What do we do with the results? Should we do cancer screens like ovarian cancer, right? Big challenging debate, and we don't have very satisfying answers. Prostate cancer recently changed to a no answer, but again, a big debate because it is such a contentious issue. We wish we had the power to make positive changes for patients, and we're still trying to figure out how can we screen them. If something good comes along for ovarian cancer screening or prostate cancer screening, it's going to go in this box, the screening for unseen disease box. So, we've gone over how to do a well child checkup and how to do an adult's annual physical. What do you think about one more visit on this list that we haven't talked about? This prenatal care visit. Have you ever thought about doing prenatal visits? Pregnancy is not really a disease. If you try to think about pregnancy as a disease, then you're trying to think about differentials and treating the disease and curing the disease, and it doesn't really work that way. But what if you think about pregnancy as a healthy condition of life, and your job as a physician is to keep pregnancy healthy for mom and the baby? Let's see if our scheme has good application for a pregnancy visit. So here's our scheme again for several of the visits that we just talked about. Let's go through a 28-week prenatal visit. Do we do screening for disease? Yes, we do. We ask a woman about vaginal discharge and leaking. We're screening for pre-labor or preterm rupture of membranes. We're screening for STDs. We ask about cramps and contractions because we're screening for preterm labor. We ask about domestic violence because the #1 cause of death for women in pregnancy in this country is homicide. That is how common and tragic domestic violence is. We're asking about fetal movement, trying to screen for fetal distress. We check weight and blood pressure. We're screening for preeclampsia. We measure fundal height, right? We're trying to measure, is there too much baby or too little baby? IUGR or macrosomia. We're trying to measure, is there too much fluid or too little fluid, oligohydramnios or polyhydramnios. But it's the same agenda item of screening for disease in this box on the grid. We listen to the fetal heart, again for distress or arrhythmias. hey, we do that sugar test, right? We have women drink 50 grams of glucose, and an hour later we check their sugar. We are screening for gestational diabetes. We screen for substance use. Do we do any counseling? Of course, there's a ton of health counseling in pregnancy. We counsel on exercise. We counsel on substance use, begging women to quit those last few cigarettes as they've cut down during pregnancy. We recommend childbirth classes as they prepare. We give advice and answer questions about when to keep working and when to stop work. We answer questions and give guidance on how we're going to manage labor together, whether it's epidurals or walking or coaches, all that kind of stuff. We answer questions and give guidance on false contractions. We talk up the value of breastfeeding. We recommend using their seatbelt, just putting it in the right place so that it protects them and the baby. How about preventive chemicals? Remember that RhoGAM thing? RhoGAM does not treat a disease, right? Being Rh negative is not a disease, it's just a woman's natural state. It is a preventive chemical used to prevent alloimmunization against an Rh positive baby, potentially in a future pregnancy. So RhoGAM goes in this box down here. What else goes there? Prenatal vitamins are a preventive chemical, and a flu shot and a Tdap are very valuable in pregnancy. So the scheme works really well for prenatal care. Why do you guys need to learn this? Well, first, if you learned this scheme, when you get good at it, you could walk into a room without any prompts because you know to get to work with any health maintenance patient on screening for disease, health counseling, and chemoprophylaxis. The next benefit is that when you're working in my office and using certain templates on my electronic medical record, and then you switch to a new doctor's office on another rotation and you're using paper or different electronic templates, they'll all look different, but you will see the commonalities in them because you know that they are all organized around having content that addresses screening, health counseling, and chemoprophylaxis. The next reason you need to learn this is once you have an idea of what kind of stuff should get done at a health maintenance visit, then you can have educational conversations with people like me and your other faculty about what should be done in each category at each health maintenance visit over the lifespan. And the last thing is that understanding this scheme will prepare you to do lifelong learning of adding and removing new items to your grid of what you're going to do at the health maintenance visit for various ages and taking out old stuff that's been proven to be ineffective, because this will be your job as you age through your career to keep up to date with what is proven to be of value. There's one more reason you need to learn this. If you don't do good health maintenance, no one else will. When it comes to primary care, it's us, family physicians, the general internists, and the general pediatricians. We're the only ones doing health maintenance and preventive care. All the rest of American healthcare is doing disease management and acute disaster treatment. The orthopedists are doing operative repairs of fractures, the surgeons are chopping out tumors, the cardiologists are treating acute chest pain, putting in stents, and they're doing wonderful, wonderful, valuable work. But they're not doing preventive care. They're not doing health maintenance. If you believe that health maintenance is important for people in this country, and if you are doing the work, then you must do it at a high level and make it fruitful, and not squander the precious 15 or 20 minutes that you have with a patient to do something productive to keep them healthy, visit by visit and year by year. Now you might ask, okay, Dr. Steinberg, you've given me this scheme of what to do, but how do I go in the room and actually do it? Well, let me give you an idea on the workflow. And you're going to like that idea of what you do in the room because these are things you're already good at. First, on history, you don't have to do a chief complaint or HPI because it's a complaintless visit, so you can blow past that. But you should get background information, because when you take that past medical and surgical history and you discover that a person had a splenectomy, you think, splenectomy. I remember that people without a spleen warrant special chemoprophylaxis. Or maybe you discover that they have type 2 diabetes. I remember that people with type 2 diabetes need special vaccines. They both actually need a pneumococcal vaccine. Or maybe you discover on birth history bronchopulmonary dysplasia. Kids like that, come wintertime, need that RSV nebulized antibody chemoprophylaxis. You can't give that patient the special chemoprophylaxis they need if you don't know these things in their background. If you discovered that someone was on chronic prednisone for rheumatoid arthritis, for instance, you'd think, this 54-year-old woman needs special screening. She may be at risk for osteoporosis early because of prednisone. I'd better start checking early. What else might you discover? When you're taking a history, you might discover some adult drinks 3 beers a day, and of course you know you should at least double that to 6 beers a day. And now they warrant special health counseling about substance abuse so that you can try to guide them to changing their behavior. Maybe when you ask about the home environment, you'll discover someone's on well water, and children in that household warrant fluoride supplementation. That's special chemoprophylaxis. Maybe you'll discover that there's a smoker in a child's home, and that warrants special health counseling about trying to protect children against secondhand smoke and getting people to smoke outside and change their clothes or maybe quit smoking altogether. Maybe you'll find out in someone's family background that there's a history of early colon cancer. Well, that will make you think different about screening the adult in front of you. You will ask them to be screened for colon cancer 10 years earlier than the relative developed colon cancer. Then, you'll do physical exam. You'll do general things like vital signs and growth charts. And I always do a general physical exam. I even do things that are not highly necessary, because healthy people, there's usually nothing to find. But people feel doctored when you touch them and examine their body and look them over. They don't realize that all 3 of these things produce the value of a health maintenance visit. They think it's the physical. So I do some physical, but I don't go crazy. I certainly make sure to include items that are clearly indicated on physical examination. Then I do whatever labs and images and testing and workup stuff serve age-appropriate screening. That's what you actually do for one of these visits. So the game plan, when you're standing outside the room, getting ready to go in and see a little kid for a well child checkup, or an adult for an adult physical, or even a pregnant woman for a prenatal visit, is now pretty clear. You're going to think, I have a scheme for this. You're going to take as much history and do as much physical exam and testing so as to accomplish age and condition appropriate screening for disease, health counseling, and chemoprophylaxis. And that will help you do a great job for the patients who are counting on you. Thank you very much for listening. Bye-bye.